Fantastic. Welcome to today's meeting of the Health and Social Care Select Committee at London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel, Hillingdon London. The purpose of this committee is to monitor services provided by health partners in adult social care and to review their performance. We also undertake in-depth reviews and witness sessions on specific topics and submit our findings to the decision-making cabinet. My name is Councillor Nick Denys and I'm chairman of the committee. Before we start, I have some important housekeeping for everyone present. Please ensure that any mobile phones are on silent. We do not expect a fire drill, so if the alarm goes off, please follow Nikki out of the building. Please keep your microphone muted when you're not speaking, and please put them on when you do speak. That's partly because people who are watching online can't hear if it's not on. Obviously, we can generally all hear each other. As chairman, I will call people to speak during the meeting. Even if it's not your own agenda item that you're talking on, but you have something to say, I'm very happy for people to contribute, guests as well as obviously councillors can contribute whenever they wish to. Okay, I think that's everything, isn't it? So if we move on to the agenda, Nikki, are there any apologies for absence?
Chairman, we've had apologies for absence from Councillor Nelson, and Councillor Pundra is here as her substitute. Welcome.
You've actually got some good loyalty points from turning up to this committee, so welcome back. Are there any declarations of interest in matters before this meeting? No? Fantastic. Okay. We have the minutes from the meeting of the 12th of October. Does anybody have any comments on the minutes, or are we happy to approve them? Happy? We're happy? Agreed. Fantastic. Okay. Every single item is going to be in public, so we don't need to worry about excluding people. And so we're going to move on to item number 5. Now, item number 5 is our main item of today, and we're going to be hearing from a variety of health providers within the borough about what they've been up to over the last 6 months and any particular challenges that they've had. So we have a fantastic cast in front of us. So actually what I'm going to do first of all is I'm going to ask everybody to introduce themselves. Before you do, actually, I've just got Philip. Philip wants to ask a question briefly. Philip, go for it.
I suppose it's a process question. Maybe it's a point of order, I don't know. This is the first of these meetings that I've been involved in that's involved any scrutiny of health partners. When I used to chair the Health and Wellbeing Board, I always thought to myself, it's this committee or its equivalent that really has the power to ask for information to perform that role properly. And if you look at the opening part of the agenda, it does actually talk about our statutory function in that regard. So with that in mind, the question I would ask is, I see we get 2 bites of the cherry in this municipal year to actually do this. And based on what I can see at the moment, although there's some good stuff there, I acknowledge, I question whether we have enough around performance, around impact in terms of service and impact on residents to properly discharge that responsibility. So I suppose I've got a question really from a process perspective. What are we entitled to expect as a committee in terms of information to properly discharge that function? Because I would question whether we have sufficient to do that this evening, notwithstanding that we're going to hear from our guests and notwithstanding the fact that we've also got presentations. So I would pose that question, please.
And Nikki, could you inform the committee about what our statutory function is and how basically the 2 meetings over the year work?
Okay, so the statutory responsibility for health scrutiny is to scrutinise health services at least twice a year. So this committee has 2 main meetings where it receives health updates. The report that's on the agenda is something that I put together and something where I'll go to the partners and ask them to update the information. It's very brief, covering information. Doesn't go into any massive detail because then it provides the partners with the opportunity to be able to verbally update rather than having too much of an onerous task on them to provide masses of information when obviously our partners are incredibly busy. We do have the opportunity in April where we look at the quality account reports and these are normally quite large. Members have the opportunity to be able to comment and submit a verbatim response to put into the quality account records. But notwithstanding those 2 meetings, we also have the ability during the year to actually look at specifics, which we are doing. So for our major topic this year, we're going to be potentially looking at something that one of the health partners does as a review topic. There will also be, for our next meeting in December, the Mount Vernon Cancer Centre. So there's a review of that being undertaken. It's been going on for a little while now. And we've got colleagues from NHS Improvement coming along to be able to talk to members about what's actually happening with that now, so how it's progressed. So there are other opportunities other than this meeting and the April meeting. But yeah, I mean, it's down to the questioning. Members will have the opportunity to question those present today, and those present today will be able to update members and give them the most up-to-date information about what's going on in their organisation.
Thank you, Nikki. I think just as well for context, obviously previously this was done by a committee called the External Services Select Committee, and which I used to chair, and that had the power to scrutinise our external health partners, but also our external sort of police partners as well. And so, in a sense, we entered into this sort of rhythm, I suppose, of the 2 meetings a year, where the April one is a lot more detailed information, but the one that we have in the middle of the year, which is this one, is maybe less information in the sort of written down sense. But in terms of rhythms of the meetings, essentially things come up again, like Hillingdon Hospital build, for example. I'm just looking at Patricia. But also, obviously, if something arises from this meeting and members want to have more information, we can and do ask for more information about it. So, Philip, is that okay?
That's helpful. Thank you.
Thank you. So, first of all, what I'm going to do is I'm going to ask Lisa to introduce yourself and just tell us what you do, because you're not going to be speaking in the main part of the meeting, but I think it's important for the other committee members to be aware of your role and what you do.
Thank you, Chairman, and good evening, everyone. Thank you very much for inviting me to be here this evening. So I'm Lisa Taylor, and I'm the newly appointed Managing Director of Healthwatch Hillingdon. Healthwatch is a charity, and we are here to represent the voices of local people in relation to health and social care services. So we engage with the local population to make sure that we're capturing patient experience, making sure that that's fed back into commissioning, into the continuous improvement of services, making sure that patient voice is central to service delivery. We also have some statutory powers as well, so we can enter and view, which means we can carry out inspections of services if we feel that there are concerns. And we also offer advice and guidance for local residents if they're not sure how to access services, if they've had a bad experience of services. We're there to listen, and we're there to act on their behalf. We also run an engagement programme for young people as well, to make sure that children and young people's voices are taken into account, that they are being listened to. And we, as I said, we're very much there to listen to residents, and so we carry out regular engagement activities as well.
Thank you, Lisa, and obviously we call on you quite a lot for information, and what Lisa does is she's essentially the advocate for the patient in the local area, so a very important person for the type of work that we do. So thank you for introducing yourself, and of course you can ask any questions at any point as well if you wish to during the meeting. So before we start properly, I think it'd be a good idea if we could go around the whole table and introduce ourselves. Councillors, do you want to introduce yourselves as well, in case anybody's watching who doesn't know you? Go on. I've introduced myself, so let's start with Philip and go around.
Councillor Philip Cawthorne, Vice Chairman, Conservative Group.
Councillor Alan Chapman.
Councillor Rita Chandel.
Patricia Wright, I'm Chief Executive at Hillingdon Hospital's NHS Foundation Trust.
Derval Russell, Harefield Hospital Director.
Nick Hunt, Royal Brompton and Harefield, as well as Guys and Tommy's Clinical Group.
Clinton Beale, Systems Partnership Transformation Manager for London Ambulance.
Good evening, Chris Reed, the Hillingdon Group Manager for London Ambulance Service.
Good evening, Dr. Ritu Prasad, I'm a GP and the co-chair and the Clinical Director for the Hillingdon Health and Care Partners.
Good evening, I'm Richard Ellis. I'm Joint Borough Director for the Hillingdon part of NHS North West London Integrated Care Board.
Good evening, Toby Lambert. I am the Director of Strategy and Population Health for the North West London Integrated Care System.
I am Councillor Sittle-Punja.
My name is Councillor Barry Nelson-West.
Good evening, Councillor Tony Bells.
I'm Nikki O'Halloran. I'm Democratic Services Manager.
Thank you very much. CNWL are meant to be here, but unfortunately had to pull out at the last minute. But we'll be speaking to them at our next meeting in December. So just for information. So the way I want to run this meeting, because I think obviously some of the members here are new to the sort of external health provider area. And I think the best place for us to start probably is with Richard and Ritu to talk about essentially the North West London Integrated Care System, how it came about and why it's important. And then after you've spoken, if Toby, you could then come in straight away and give a bigger context about the North West London and how that works. And then after we've had that, then we can open up to any questions that councillors have on that specific part. So, Richard, would you like to go first?
Thank you, Chairman. Thank you. So I've worked in the local Hillingdon Borough team, I guess, for about 18 months now, and the Hillingdon Borough within what was North West London Clinical Commissioning Group and is now North West London Integrated Care Board, I think has worked with every single partner around the table to support effective delivery of health and care services for the borough. Lisa and I have just come from a meeting all afternoon looking at general practice services and local phlebotomy services and a number of other areas. And our team, linked with the North West London overarching team, provides specific commissioning services for primary care within the borough, mental health services, children's services, the range of joint commissioning around older people's, also mental health, and oversight for the delivery of integration between and across local partners in health and social care. And I've said a word in my paper on, I think, page 12 for members' reference, that we're now actively working with the local authority, of course, with the Director of Public Health, with the Director of Adult Social Care and the other key leads in the local authority, with planning, with housing, on a lot of important areas, and working specifically with general practice around developing and improving general practice access for patients, particularly over the winter period, and supporting key practice-based services for patients such as phlebotomy, which this committee has paid attention to in the past. We're working with Hillingdon hospitals, of course, on supporting them in the flow of patients through the hospital and ensuring that the discharge processes are running as smoothly as we possibly can. And working very actively again with the Director of Public Health on planning for winter, which officially, of course, started a month or two ago and runs, I think, through till the end of March, and maybe will become a 12-month season. We never know. And obviously working with the London Ambulance Service very actively along that. You'll remember that the Confederation, the GP Confederation, of which Dr. Prasad is the chair, played a crucial part in the delivery of our COVID vaccination program this time last year, when we were very pleased to report that Hillingdon was the highest achiever in COVID vaccinations, not only within North West London, but also across London. And I think that probably means across the country as a whole. So a very effective vaccination program for COVID last year, active program for flu and for COVID vaccination this year through general practice and our community pharmacy colleagues, and also the catch-up of polio vaccination for children who missed out the first time around. And I think in CNWL's absence, it's worth just reporting on the successful opening of the crisis house a few weeks ago, with capacity at the moment for 6 mental health clients. We hope to be able to increase that in the coming weeks and months. And I think that has already, in ones and twos, helped to reduce a little bit of the pressure on Hillingdon Hospital's A&E, where unfortunately a number of patients with mental health problems can occupy A&E disproportionately for longer periods of time than is right for them or is right for the department or, of course, right for LAS. So we hope that the Crisis House is a bit more than a drop in the ocean on that, and we want to support that. And we are working with the Metropolitan Police, another partner who has been around the table to the Select Committee, around improved crisis services for mental health. Again, hopefully supporting London Ambulance Service and the police in providing better services, particularly for patients brought under Section 136. And I think we in the borough team try to support and to support each of the partners within Hillingdon Health and Care Partnership, which I'll ask Dr. Prasad to say a bit more about in a minute, and to work with the individual partners, but of course also with the grouping of Hillingdon Health and Care Partners and the local authority, and most importantly with the individual programmes and the staff within the North West London Integrated Care Board. So I might pause there, Chairman, if I may, and perhaps pass across to Dr. Prasad, where we have a brief presentation on the work of Hillingdon Health and Care Partners.
Dr. Prasad, before you start, can you just explain what the Confederation is, just for those who aren't aware?
So the GP Confederation is an overarching body of which all the GP practices within Hillingdon are stakeholders. So the Confederation represents primary care as a unified voice. Plus, it also represents a partnership within the Hillingdon Health and Care Partners from general practice point of view. The GP Confederation is also an overarching body over all the primary care networks within Hillingdon. So we've got 6 primary care networks, and the Confederation supports the development and the delivery of care through the primary care networks. So that is what the GP Confederation is. The GP Confederation, Rich has just mentioned about the vaccination program, so it also provides services that need to be done at scale for the population of Hillingdon. So, for example, the COVID vaccination or the development of the hot tubs during the COVID time and various other sort of delivery of out-of-hospital services. So we work very closely with our partners in the delivery of care, more closer to home for the patients. So that's the role of the GP Confederation. So are you happy for me to proceed? So I'll just give a little bit of recap about what Hillingdon Healthcare Partners are. So we are an alliance of health and care organizations, which is represented by Hillingdon Hospital Trust, the GP Confederation, CNWL, our community care provider, and H for All, which is the voluntary organization. So we have formed an alliance, which is a partnership to deliver new models of transformational work so as to improve the delivery of services and work in a more integrated way. We also work, since the inception of the HHCP, we worked very closely with the Hillingdon CCG at that point and with the local authority as well. And some of the examples that I will give you as we go along will demonstrate how we've done that. Our strategic aims are obviously to improve the outcomes of our population and by delivering the Hillingdon Joint Health and Wellbeing Strategy, and also to deliver sustainable person-centered, joint-up models of care where we truly develop care that can be given outside of hospital, and that also supports the new build of the hospital going forward. And the delivery of obviously the North West London integrated care systems priority through our local models. And our delivery models are, I'll go through a few of the things, 6 of the neighbourhood teams. So our PCNs are aligned to our neighbourhoods. So we've got 6 PCNs which are geographically aligned within Hillingdon. And these...
Could you just explain what a neighbourhood is?
Sure.
Just because
sure.
I'm conscious these are terms, obviously,
Fine.
that you know very, very well and I know a bit about, but some
Sure.
people won't understand that.
In 2019, July of 2019, the primary care networks were set up. So these are a group of practices working together, serving a population of about 30,000 to 50,000 patients. And these services, so it's combining GP practices who deliver integrated models of care and also delivery of services that are best delivered in an MDT fashion as well. So the neighborhoods are a bit wider than that. So you've got the PCNs, which are the GP practices, with their additional workforce that we have. And the neighborhoods are services and our community. It's starting right from the patient level to voluntary agencies, to our community care providers, schools, ambulance services, police services. So whoever is within that locality is our neighborhood. And that's where we all join up to provide care for the patients in a joint-up manner. So that's the neighborhood concept and the primary care network concept. Is that okay? So as I explained, our delivery models integrate all of our 4 partners. Moving on to the next slide. So what is the Northwest London Integrated Care System brings together health and care partners with the 4 specific aims of improving outcomes, as I said, in population health and healthcare, tackle inequalities and in outcomes and experience and access, and enhance productivity and deliver services that are value for money. Also help the NHS support the broader social and economic development as well within the community. And since the inception of the Northwest London Integrated Care Board in July of 22, this was established, and this is overseeing all the 8 Northwest London, which was an integration of the 8 Northwest London CCGs. And at a borough level, the focus is to build and strengthen the partnerships between health, voluntary sector, local authorities, and the stakeholders, including our patients who are our main stakeholders, to work together to improve the outcomes for our residents. And these have become more formalized during the year. This is going to become more formalized, and once we take on the delegated function from the ICB in April 2023. And the work that has been done with HCP partners and our local CCG up till now has put Hillingdon in a good position to be able to deliver the ask. Moving on to the next one. So we've refreshed our plans and the ways we work. So in a way, what we've tried to do is to align our health and wellbeing strategy along with the Northwest London strategy and what we were doing, and focused on 6 of these priority areas, children and young people and families being one of them. And what we want is if we are able to give our children and young people a good start, that is one of the most important things we can do to improve the outcomes in the future as well. And tackling unfair and avoidable inequalities. We know that Hillingdon is a very sort of varied borough with different kind of people from different backgrounds, of different socioeconomic status, different languages and cultures, and that is what we try and tackle within Hillingdon as well. So helping people prevent onset of long-term conditions such as dementia and heart disease, and there's a big focus on the prevention of cardiovascular disease to reduce the burden on healthcare systems and also improve the quality of life for our residents. And supporting people to live well independently longer in old age and throughout the end of their lives. Mental health has been a big focus, and we are working with CNWL and all our partners in helping people achieve better outcomes for people suffering from mental health problems, and prevention and empowering patients as well to help to manage themselves as well. And improving the ways we work within and across the organizations to offer better health and social care. So this is what our Hillingdon partnership is focused on, and these are in line with the 3 priorities of Northwest London and also our local sort of health and joint well-being. There's a lot of focus, and we've been working on population health management. Lisa's been involved, and Kelly has been working with us on population health management, and there's a huge focus on delivering the needs that have been identified. Falls and frailty is something that we have identified as a key priority for Hillingdon, and that's a project that we're all working on together as well. There's also been a focus on working on in Hayes and Harlington. Another sort of project on population health management is undertaken, and this is to deal with mental health problems, obesity, specifically with the diabetes in the south of the borough as well. So we've kind of worked on a framework, and we've worked with a company called Optum to develop a methodology to deliver this population health management needs that we've identified. How do we get the outcomes? And we're working with our patients, which Lisa has helped us a lot with, to get what they really want and then address them in that way. So this is a little bit about what we're doing with the population health management. And the Core 20 obviously is Core 20 plus 5 is the key priority. 20%, the top 20% population that is deprived, maybe it's socioeconomically or from various other reasons, tackling those inequalities within Hillingdon as a borough, and then the 5 key pluses, which are maternity service, mental health services, respiratory, and early cancer diagnosis and hypertension diagnosis, early diagnosis and management. So just to summarize, looking forward, we have 3 themes to work on over the next year, and it's to develop Hillingdon as a place where we embed population health management, address the areas of inequalities that are there within Hillingdon, and defining place governance and accountability, including the voice of our residents, which is really key, and ensuring a joint up and best use of resources amongst all our partners. Building Team Hillingdon, we're very proud of Team Hillingdon because we've worked, and through COVID we've developed a very close relationship, and that's how it's not just the GP Confed who was able to manage all the vaccination. It was a joint effort, and everybody pushed the kind of, we always wanted to stay on top, and it became like a competition for all of us to stay on the top as well. But it was a joint effort where we worked really well together. So we are really proud of Team Hillingdon, and that's the team we really want to work on. And obviously then it's a delivery of transformation programs that we identify, which are in line with our 6 transformation key priorities as well. And the next steps, obviously, I've just mentioned about population health management and engagement, and establishing priority areas from the refreshed joint strategic needs analysis as well. So we're working on various projects. There are other needs that have been identified, and these needs have been also localized in different sort of neighborhoods or parts of Hillingdon, and we're going to be working on those. And the key aim at the moment is the resilience amongst our partners, so that we can support our hospitals and other key partners within Hillingdon, and delivering our objectives, including the transformation programs, and working with the North West London ICB. Thank you.
Thank you. So I think what would be really good is for Toby now to sort of talk to us about basically what is the ICS, why does this exist, and what does the North West London element to what Richard and Rita have talked about, what do they mean? I think Nikki's just changing slides. And then we'll come on to questions for all 3 of you, because I think it's important to understand how it all works together.
That's somewhat of a tall order. I sometimes feel the reason that so seasoned NHS watchers will know that we shuffle the commissioning side of the NHS on a reasonably regular basis, and sometimes I think the main reason for it is to keep us all on our toes with what the various different acronyms and so on actually mean, but I shall do my best to bring some clarity.
As soon as it starts to click and you understand it, there's a new reorganisation. Is that how it works in the NHS? So, after my 3 years here.
Well, I can see a number of wry smiles from some of my NHS colleagues. So there is some truth in what I'm saying, even if I'm sure our masters in the Department of Health and Social Care would not agree with that. So Dr. Prasad has covered some of this, but I shall try and bring as much clarity to it as I can. So on the 1st of July, the integrated, on the 30th of June, clinical commissioning groups were disestablished, and on the 1st of July we have a number of new organisations / committee structures come into existence, and the main 3 of which, for the purposes of this, are an integrated care board, which is in many ways the successor to the North West London Clinical Commissioning Group. So our primary function is to sort of commission NHS services on behalf of the population of North West London. Also established on the 1st of July is something called an integrated care partnership across sort of North West London. That's not an organisation per se, it's a committee, and it's the committee which brings the NHS and local authorities together. And its primary function is to set a strategy for health and care, again on behalf of the sort of population of North West London. And both of those things are part of something called an integrated care system. And the integrated care system is basically everyone who is involved in the commissioning, oversight of and provision of health and care services in the whole of North West London. So including the sort of London Borough of Hillingdon as a local authority, as well as us as a NHS organisation, indeed all of sort of my colleagues from the health service who are in front of you sort of today. So the integrated care system is that all of the organisations sort of coming together. It doesn't have a sort of budget or staff sort of per se. It is just a sort of catch-all term for all of these sort of providers and sort of commissioners of health and care services sort of across sort of North West London. So it includes, as I said, 8 local authorities, all of the trusts, sort of many GP practices. It says 347 here. I think I've got 350 somewhere later on in the presentation because the number changes a bit. But voluntary organisations, sort of everyone. We're set sort of 4 objectives sort of nationally, which Dr. Prasad has also covered off in her presentation. So improving outcomes in population health and healthcare, preventing ill health and tackling the inequalities in outcomes, experience and access, productivity and value for money, and then that sort of broader economic and social development, which is essentially how can we use our collective heft in ways outside the formal sort of health and care infrastructure to deliver sort of wider benefits. So the NHS in North West London employs 65,000 people. No doubt we can, through our hiring practices, provide broader benefits to our sort of local population than purely providing health and care services to them. So that's the idea behind that. Same point, more numbers. The Integrated Care Board is practically known as NHS North West London, which by some coincidence is exactly the same name as what the Clinical Commissioning Group used to call itself. And our main sort of function is to sort of commission care on behalf of the population of sort of North West London. It basically breaks down into sort of 3 sort of areas. So one is helping to develop a strategy for the services which we commission. The second is some sort of coordination / oversight of the delivery of those services. Obviously the providers of care actually deliver the services, so our function is the sort of the glue trying to bring that together. And then sort of lastly we have a role in the assurance of those sort of services, so on behalf of our sort of NHS England. The reason I think sort of paraphrasing the sort of various policy documents on this, we shifted from a clinical commissioning group to an integrated care board is to bring a greater stress to the integration of services between the sort of the different actors. So not to say that the previous organisations were not already trying to integrate services, but the governance of the Integrated Care Board has providers of care on it, it has local authorities on it, it has primary care on it, so there is a move towards that greater integration sort of embodied in that. And then the partnership is as I said, it's a committee, it's not an organisation, and its primary function is to sort of develop a strategy covering the whole of health and care. As a committee rather than an organisation, no budget, no staff. So the thing with the budget and the staff is the Integrated Care Board. That Integrated Care Partnership, chaired by our chair, co-chaired by our chair, Penny Dash, and an elected member currently, Councillor Nick Denys, who is the chair of the Health and Wellbeing Board in Westminster. Underneath that sort of overarching North West London-wide structure. We continue to have sort of borough teams as an integrated care board, of whom sort of Richard is a part, and then we continue to have the local collaborations. We call them borough-based partnerships, but the one which you will know is Hillingdon Health and Care Partners, and that sort of continues as the sort of local vehicle for collaboration. Okay. So, one of our first orders of business as a integrated care board within the integrated care partnership is to develop that strategy for health and care across northwest London in order to deliver the 4 outcomes which we have laid out. So that is an ongoing process, and we hope to have an initial strategy at some point early in the new year. It is very consciously building upon the joint health and wellbeing strategies of the individual boroughs and your joint strategic needs assessments. So it is in many ways a bringing together, and where can we, at least from the North West London level, where can we deliver or support people to deliver further and faster by bringing it together at North West London, while ensuring that those priorities which are particular to boroughs, or that the boroughs think they are best placed to continue, have sufficient space, support and resource in order to deliver on those. So it's a bit of the age-old balance between where can we go further and faster by developing scale versus where is the local knowledge and delivery the best, most effective way of coming at it. So we haven't quite landed that one yet because we're still in the process of developing it, but that's what we're trying to balance in that. Number of reasons why we're doing that. I won't go into too much, but that strategy, as I said, it's building on the joint strategic needs assessments, those joint health and wellbeing strategies, and it is likely to be delivered through a number of programs and networks which we have established at North West London wide level. There's proactive population health and inequalities, which is the population health bit of my title. SRA for that is the Chief Executive of the London Borough of Hounslow. We have a local care, including primary care programme, which is where the bulk of the work, but by no means all of the work, which Richard and Ruta and the Hillingdon Health and Care Partners fits in. Mental health programme, an acute care programme, data and digital, whose SRO is sitting opposite me today, embodying some of the points of how we get that integration to actually work in practice, workforce, finance, research and innovation, and then a couple of the networks around cancer, maternity, children, and young people. And that basically gives you the same list in a slightly different format. So I hope that has helped to demystify some of what is how it's going on.
Thank you. Do we feel demystified? I think it took me about 2 years to get close to understanding all of this, by the way. So, I've got a couple of questions for the three of you. Then I'll open up to others who want to ask questions. So my first one is essentially, how is a funding decision made? Because obviously health is very important, lots of different aspects of health, lots of different needs, and essentially within this system there must be different views depending on perspective, from the neighbourhood, the individual GP to the neighbourhood, to all the way up to the boards that you've described up here. So how do you decide what you fund?
So, still working out as part of the answer on this, because we haven't got everything sorted from the 1st of July to November. But in essence, we are commissioning directly the NHS trusts. The commissioning of primary care and continuing healthcare and a number of other services is done locally. So we make a decision on the allocations to those different organisations at the moment, so the trusts, and the borough-based partnership, Hillingdon Health and Care Partners, then has the ability to bring together those partners locally and say, actually, how we want to spend it with our local priorities is a bit more on this and a bit less on that. So resettlers are all the broad bits, and the more detailed working through and alignment with local priorities sits with the borough.
Thank you. So Richard and Rita, can you explain in sort of practical terms, maybe an example of how this works in practice? Because obviously Toby, you're sort of the helicopter dropping money on us, hopefully. And then Richard and Rita, do you sort of pick it up and decide locally how to do things? Is that how it works?
So I think, as Toby says, it's still in process, and very much a progression. I think with Hillingdon Health and Care Partners keen to take on more delegated budgets, as I think Dr. Prasad mentioned, and clearly North West London ICB, as the accountable NHS organisation, are responsible for delivering a balanced budget across the ICB, clearly wanting to be assured of the spending of public money properly. I mean, as Toby says, the borough team is responsible directly for two budgets: the primary care budget for local primary care, and for the Better Care Fund, clearly in partnership with yourselves and with other health organisations. But an example, I think, for other funding would be the Winter Planning Fund, whereby North West London ICB would receive several pots of money from NHS England, and some of that money we will receive on a population basis to Hillingdon. I think Toby will agree, and hopefully other colleagues, that Hillingdon always fights for more than its fair share of the population-based funding at North West London level, and then at borough level we have a number of governance groups mainly within Hillingdon Health and Care Partners, of looking at the overall funding available, the overall objectives that we as a local health and care system, with THH, with primary care, with the NWL, with the voluntary sector, with general practice obviously, how we look to identify projects over winter to support local residents through what we expect to be a very difficult winter, and in partnership with social care, with the hospital, with other partners, agree exactly which projects to be funded. Often North West London will ask us, if not for a business case, at any rate for a justification of why project A rather than project B should get funded, and clearly how we propose to monitor those projects over the winter season. And a second example, I guess, might be the health inequalities funding that Dr. Prasad mentioned, where we're working very closely with the Director of Public Health on identifying how Hillingdon will want to allocate its share of the overall North West London pot, and how we would like to influence the North West London programmes on how they allocate their 40% of the pot. But I don't know, Rita, if you'd want to add anything more specific on allocation of funding.
I think you said my role is not within the funding, so I work more with the provision of the services. So as Richard has just mentioned about the local sort of needs and analysis, so my role would be in bringing out projects and proposals that would benefit, and then obviously we would go through a joint up decision making process whereby projects that will really benefit and will address the needs of the local population would be assessed. So that's my role. So I would not be directly involved with the commissioning, but obviously work very closely with the commissioners so that they're supportive of projects that would benefit the population.
Thank you. Well, obviously your intelligence about what needs to be done must be very, very crucial to know asking and then evidence for making decisions. Yeah. I mean, obviously the reason why I asked this question is because this is one of the issues when the ICS was first formed. There was worries about the balance tension of it, because obviously, that who makes those decisions, who knows. So I'm sure that's something that we will definitely revisit. So, but my second question, because I know we've got a long night ahead of us and others want to ask questions as well, is about maybe more towards you, Ruti, about the Confederation. Now, because you said Team Hillingdon, a football analogy came into my head, and I'm going to run with it. If it's a disaster, let me know. I can re-answer the question. But two of the slides that I really picked up upon were like the 4 outcomes and the 3 themes. 4 outcomes was in the middle, 3 themes were at the end. You know, they seem to be very, very good ambitions for us to have. But I suppose my question is, how do you know you've met them? How do you evidence progress? Because obviously from our point of view as a scrutiny committee, I think we'd probably say those 4 outcomes, 3 themes seem really good. But how do we know how we're doing on those?
Transformation projects that we plan and then deliver have, obviously we set, right from the beginning, they are set KPIs that would be set out as to what we're wanting to achieve with that. And then the targets are assessed on a regular basis. Are we managing to achieve that? For example, we've got the Care Connection teams. Now, these are teams comprising of specialized guided care matrons and care coordinators and wellbeing officers who work very closely with primary care to address the needs of the top 2% high-risk patients. And one of the key elements is that how many of these patients have we avoided an emergency admission. So those are set criteria, and then obviously when you're admitting, you're also looking at the financial benefits of keeping people at home and treating them in a place where their needs are best met. So working across these KPIs, that is how the assessment is done of every project. Similarly for the care home services, it could be something like how many deaths have we, like people within care homes, what is their place or choice of where they would like to be towards the end of their lives? Have we managed to achieve that? So these are the key kind of targets that we would set right from the outset and make an assessment and obviously analyze them on a regular basis, because services that you design obviously need improvement on an ongoing basis. And if things are not working towards the key targets, then obviously changes are made in how we deliver those services. So that's how we manage to address and demonstrate that we're achieving those targets.
I think for us as a committee, when we do our April meeting where we have the more detailed reports, it'd be very, very useful to get that, in statistical form, or also obviously anecdotal form where that works well, because for us as a committee to get a feel for whether those are being met, I think is a very important job for us. So, okay.
I'd be very happy to provide you with the details of some of the key projects that we are undertaking in Hillingdon.
Fantastic, thank you. Right, so I'm going to open up to the rest of the committee. Philip, you had your hand up.
I did, yes. Okay, I'll go first. A couple of questions, and they're not dissimilar to yours, but perhaps with a slightly different angle, Chairman. And I suppose it's this question of local subsidiarity that's been referred to already. If I were feeling mischievous, Richard, I might ask you whether you're the ICS's rep in Hillingdon or Hillingdon rep in the ICS. I'm interested really in. We have a health and wellbeing board in the borough. Certainly we used to have commissioning intentions that were signed off on a regular basis, and it all started with a joint strategic needs assessment. I'm wondering whether moving to a regional way of doing things, I suppose not dissimilar to the old strategic health authorities, I wonder if there is perhaps a democratic deficit arising out of that potentially, or do all boroughs' interests align in all cases? But I would suggest possibly they don't, and I would suggest there are characteristics that are different in different areas that need to be taken account of. And at least the Health and Wellbeing Board, I suppose, brings a measure of democratic accountability to the work of the health service, which I would say is much needed. So no doubt there are economies of scale along the way, I'm sure there are, but I'm just interested a little bit more in how the relationship between the Health and Wellbeing Board and all they do and the wider ICS system works. I think I'll leave it at that. Thank you, yeah.
So, to be honest, still slightly a work in progress. I can't really comment very much on the sort of nature of the democratic deficit, in the sense that the sort of current structure is sort of set nationally, and there is hence sort of limits onto what we can do. We certainly can't turn ourselves back into 8 individual integrated care boards, one for each of the boroughs. What I will say is that the strategy and then the plan and then hence the commissioning intentions are being built up from the joint health and wellbeing strategies of the 8 individual boroughs, and hence from the joint strategic needs assessments of those 8 boroughs. We haven't had a full cycle as yet, because we were established on this on the 1st of July, and we are only in November at this point. But certainly we are setting it up to be able to show those areas where some degree of scale and heft actually is going to make a difference, and makes sense to try and do it once across the patch, because it will enable us to get there further and faster, because it's a more efficient and effective use of resource, but at the same time ensure that there is sufficient space within that overall framework for those local priorities to continue. So, having had the pleasure of reading all 8 joint strategic needs assessments, and not quite yet all 8 joint and health and wellbeing strategies, as some of them are still in formulation, but I've read the drafts of the ones which aren't quite there. What you certainly see is that there is a large degree of commonality between the boroughs, and in fact there are greater differences between areas in the boroughs than there are differences between the boroughs themselves. But what the process is going to, we are currently running, is to say, so for these areas we can see why working together makes more sense. For these areas, even though it may be an area in common, actually we don't see the sense in working together. For these areas which are particularly specific, then perhaps we shouldn't be working together at a North West London-wide level on them, but there are, even in those, some particular areas where the individual boroughs would appreciate some support from the greater scale which North West London could bring. So the issue of the day, as a reminder, coming in, is something like the to asylum seekers and how those disproportionately affect some of the boroughs in North West London compared to others, and is this not an opportunity to use some of that greater scale to provide some more bespoke support to the areas which are disproportionately affected by that?
Thank you. Richard, you indicated as well.
Just to reinforce that, I think from Hillingdon's point of view, the Health and Wellbeing Board is an extremely important forum to test our local ideas, to hear the board's views about strategy. I think our local objectives and as Dr. Prasad was saying for HHCP, I think they are informed by the Health and Wellbeing Strategy and by the Joint Strategic Needs Assessment. And I think we locally gain an enormous amount from the input and resources of the Public Health Department when we were working on the vaccination programme during last year and during this year, seeing at ward level the coverage of the COVID vaccination, where we were succeeding in reaching local communities and where we were not yet reaching the coverage that we're expecting, was enormously helpful in focusing down even to that small level. But being able to call on North West London's overview when there was something that at borough level we couldn't do was really helpful as well. And Toby's mentioned the asylum seeker point. That's exactly sharing a direction of public health across Hillingdon and Hounslow, the two boroughs with most hotels and residents. There's a commonality of purpose, even if there's a diversity of application and a locality of application that I think is certainly helpful for Hillingdon, and I would argue probably helpful for other boroughs as well.
This is one of those areas I think over a number of meetings we'll be delving more into. So, Tony, you had a question.
Yeah, thank you, Chair. I like what you said about the prevention schemes. There seems to be plenty of evidence that this is happening, and I'd like to think you're reaching all the hard-to-reach communities in the borough. But I'm constantly getting messages about get your blood pressure checked and events going on, etc., etc. Just want to turn about GP recruitment. How do we stand in the borough? Because we always hear in the news about the turnover of GPs, etc. Where exactly are we in the borough? Have we got many vacancies at all?
So Hillingdon is currently slightly under-doctored, yes, but recruitment, we are doing a lot of work with our training hubs, which the Confederation runs as well, and it is to encourage and support GPs and bring back GPs who would want to come back and work part-time as well. So there's a lot of work going on as well for GP recruitment, and Hillingdon is also given preferential sort of arrangements for increasing the number of GP trainees that they send to Hillingdon so as to encourage their retention later on once they've trained up as GPs. But it is, I think at the moment it's just about manageable, but then yeah, it is, it's a nationwide problem with GP recruitment. But Hillingdon seems to be doing okay at the moment, and with the extra help that we've got, hopefully we are training more and more GPs within Hillingdon as well.
Thanks. Thank you for your answer.
Just going back on this, because I kind of see that this need for an integrated service, because I think integrated services where the dots are all kind of joining up is quite an important thing. Something that kind of just occurred to me when you all were speaking, and something that's happening in other public sectors, is this extraction of resources to put into different places as different communities and different boroughs or whatever need them. And we've seen this happen in the police service. And I just kind of want to know what how you're mitigating that, and how you're making sure that actually boroughs are keeping their resources intact, because at Hillingdon we do need them. And for example, I mean, I know we think that we're saying that GPs are okay, but we really aren't, are we? It's not the truth, because we've got waiting lists and patients. I've got employees who can't see a GP, and I don't know how the GPs are being monitored, because some of them are going online and some of them are seeing face to face. I'm quite lucky, I have an amazing GP service, but I know others don't have the same kind of resources. But that resources and having the extraction of resources going into other areas in this integrated service is a little bit of a concern, and I just wondered how the ICS were going to manage that.
Do you want to get first go on that one? Okay. So I think this is one where, first of all, we have to sit back and have a look at sort of the larger picture. So we know that nationally we have a shortage of general practitioners. That's undoubtedly true. Dr. Prasad has just said that we have a slight shortage in Hillingdon. It's not quite as bad as the national average, but it's still short. On the other hand, alongside the general practitioners, we have an increasing investment into alternative roles, essentially to move some of the the lower value-adding tasks which some general practitioners have been doing to other members of their team who are perfectly qualified to do those tasks, to free up the GPs for these higher value ones. And some of that is a shift in technology as well. So GPs rarely take blood pressure these days and so on, so that sort of thing. So we do have a increasing investment in the the non-GP part of primary care workforce. We also have across North West London, Dr. Prasad may know the numbers for Hillingdon, but across North West London, we're currently delivering about 39% more consultations in primary care than we were in 2019, before the pandemic. So what we've got here is slightly less a squeeze on the capacity side. There is a squeeze there, but a very big increase on the demand side. So that's really what is driving the waiting lists and the difficulty of accessing general practice. So rather than resources have been extracted from general practice and taken somewhere else, and in fact, and the universal level, we put more resource into general practice. It's this demand bit that is going up, and that's where the some of the North West London wide support comes through into the how do we better manage that sort of demand. So there are practical examples like sort of bringing in sort of more up-to-date or telephony services, so people don't hang on their sort of phones, and then so the 8 in the morning rush to sort of try and get the that day's appointment with your GP, and if you manage to get through it sort of 2 minutes past 8, so you're now told all the slots have gone, and we've largely managed to mitigate across sort of North West London. So there is some sort of practical sort of North West London bits about sort of how we're sort of managing the demand. So in summary, we're not extracting resources out from general practice. We do have an issue with the sort of demand having gone up sort of very sharply after the pandemic. Some of that is driven by sort of demand which didn't manifest during the pandemic. So we know, for example, that our hypertension control rates have come down because people weren't being seen during the pandemic, and now they're returning. And it's how do we sort of get the how do we manage sort of that extra sort of demand, partly by adding sort of capacity within primary care, but also by thinking about sort of how can we do that sort of differently and try and shift some of that demand to sort of less sort of intensive channels. Do you want to pick up after that?
Yeah, it's right. I mean, the number of appointments has gone up. It's over 35% increase in the number of appointments that were offered before. It's just the demand is so great at the moment that that is the reason people can't get to GPs. With the digitalization over the COVID period, obviously it's open channels. So if you imagine people were ringing before just to get appointments, now they are getting to general practice through digital means. They may be putting in a digital sort of consultation, which we have to address. So in general practice, we're dealing with all these kind of elements of patient contacts. Some of them really needed, and plus we've also got people with long-term conditions who we are obliged, and we have to ensure that they have been looked after. So you're trying to deal with the continuity of care and the long-term conditions and the daily demand. But as Toby just mentioned, with the evolvement of the PCNs, we've had additional workforce in the form of clinical pharmacists, social prescribers, health and wellbeing coaches, paramedics, physicians associates. So we've built up the number of people who can help the GPs deliver that care. So even though the GPs, we're still struggling with the numbers, we've had this additional workforce which we are utilizing to deliver and deal with the demand as well, and plus also address the needs of the people who really need them with the long-term conditions as well. So it's a kind of a juggling act, but it's just a question of excessive demand at the moment.
Cool. If it's okay, I'll move us on to the next people to speak, because obviously we spent quite a long time on very important on the structure and of how health services are provided. If we can move on to the ambulance service, if you could give us your presentation, then obviously if we have any questions at the end of that, we'll ask you. So, Clinton, are you going to go first?
I'm going to go first. Just to explain, so my role sits across North West London and Pan London, and Chris is the senior man looking after Hillingdon. So we're going to tag team a little bit here, depending on what the questions that come out. So just some scene setting is the LES, or the London Ambulance Service, is the only Pan London NHS trust. And we are currently the busiest ambulance trust in the UK in terms of volume of 999 calls and 111 calls. We're approximately doing about 3,000 emergency jobs every day. We're taking about 2 million 999 calls every year. So that just sort of scene sets in that sense. And a lot of our work is done. We have to look across a Pan London or a North West London picture, and sometimes that struggles us when we're doing stuff at a local borough level, because we need to make sure that we can extrapolate that across our workforce. We look after both the 999 and the NHS 111 system across London, and they're doing about 1.2 million calls a year at the moment, and that is rising. We cover essentially inside the M25, all around 620 square miles, and we have a workforce of approximately 8,000. We work very closely with our NHS partners, specifically the ICB. We're definitely much in conversation with them almost daily, I would suggest, with your colleagues, in a good way, I hasten to add. I think while I mentioned that at the top of that conversation, the collaboration that goes on between the ICB, the London Ambulance Service, the acute We are almost in contact daily, and it's a very collaborative conversation. It's about trying to solve processes as opposed to and deal with the problems that come up as a shared risk. And I think this is kind of a new vision for us. I think as a system that actually a risk for the ambulance service. Ultimately, a patient in the community that doesn't have an ambulance with them, and there is an absolute risk there that we don't know what's wrong with that patient other than what we've been told over a telephone interrogation, versus the risk of 50 patients in the emergency department, and us taking more patients to that full emergency department. And then the obvious issues we know with discharge and community services. So it's really becoming a shared risk, which is really helpful for us to actually not just push the problems around, but actually try and solve the issues within the wider system. It's really helpful to know collaboration in terms of the other emergency services, so the Metropolitan Police Service, the London Fire Brigade, the London's Air Ambulance, and the London Resilience Forums. Means we are always ready and prepared to respond to any major incident and ensure we keep Londoners safe under our statutory requirements to do so. That always sits there on top of that. That does cause us challenges, as you can imagine, because keeping those additional significant resources available, both in terms of staffing and equipment that needs to be kept ready and essentially unused is a challenge and takes a lot of effort there. We are always seeking to improve how we operate, and by integrating our 999 and 111 services, we are treating more patients over the phone than we ever have done before, in their home, or referring them into appropriate care within their community. And that's been a challenge for us, certainly as we've in previous years, in terms of, generally speaking, the ambulance service turn up and it's a snapshot of a patient that we're seeing, and actually it was very difficult for us to see patient records at the patient side. So actually, if you've got a patient who, and without going into details, if you've got a patient who's got a parameter that is outside the normal range, that would generally necessitate a ambulance journey into hospital. Actually, if we've got access to the patient's records and we can see that actually is a normal parameter for that patient, actually we can make some better informed decisions on the patient's care in that sense. And that certainly leads into the urgent care plan, which is a process, a system where GPs and other healthcare professionals can basically produce a plan for that patient and then record it on the system, and our paramedics and non-registrants can see that urgent care plan on way to that patient, and so they can make a very, very informed decision on where that patient goes or not, as the case may be, which is really powerful for us. And I think that leads on very much to technology in this conversation. Technology has moved on in the last couple of years, leaps and bounds for us. So all of our staff are now issued with a tablet which enables them to access that urgent care plan, also enables to access the NHS number and other records that are on there for that patient. And that's really valuable, and it also allows us to share that information now. So over the last couple of months, we can now share that information with hospitals that we are going to, so they now have access via a web portal to all of those records of patients that are going into them. So things like ECG strips and other patient information can be seen before we arrive at hospital by the hospital staff. And there's further information going on with that process where it will eventually be integrating into hospital systems. So it will be improving the processes in the administration of those processes. And in terms of data, certainly monthly, we're doing, as I said about the 111 calls, we're doing about 26,000 111 calls. We are here and treating, which is doing over the phone and basically closing that case over the phone, about 14,000 of those calls. 11,000 of those calls are being triaged into the A&E via 111. So although it's gone through 111, it still ends up as an A&E resource sometimes, but that's okay because it's about how we're using the whole system. And 31,000 patients on a monthly basis are being treated at the scene and then discharged at scene. So we are. Please.
Sorry, could I interrupt you just?
If you don't, I'll keep talking.
I'm partly conscious of time,
please,
obviously, as well, and I think what really interests us as a committee is obviously what's happening in Hillingdon.
Yep.
And obviously you do see statistics, and actually I went to a meeting of the joint North West London Scrutiny Committee. The chairmans of all different joint West London Scrutiny Committees meet 4 times a year, and if you can imagine a committee made up of chairmans, it does go on for a long time, but it's very useful. But I think we got some statistics around performance, didn't we, of ambulances in the papers, Nikki? So if you could circulate that to committee members after this meeting. But I suppose to get to the meat of it, obviously we've seen in the news the pictures of obviously ambulances outside hospitals and the delays that are happening. Now, none of those pictures I've seen are in Hillingdon, which is great, obviously, but I suppose what I really want to know is what is happening in Hillingdon in terms of ambulance response time, and also in terms of how you feel it's going in being able to, once you get to the hospital, shift patients into the hospital. I know Northwick Park counts as well for you guys, because you're not, thankfully, sort of shut off by the border. So if you could talk a little bit about that, and then we could open up for further questions, if that's okay. Obviously, if there's something you really want to tell us that I've cut you off, do take that thing as well.
I think questions are good, because actually I could talk for hours about
it was interesting, but I think we want to, that's where we want to get to. So if you can talk to us about response times, how that's looking, including like response times obviously for emergency and non-emergency, or however you categorise them, but also your experience in terms of how it's working with the hospitals in terms of being able to shift patients to where they need to be and then moving on. So, yeah.
Thanks. Yeah. So I suppose if we start with the response times at the moment, we are in a challenging time. There's no two ways about it. We have different categories of call. So whenever a 999 call made, it is categorised into either a category 1, which is the highest acuity call, so it's cardiac arrests, fittings, and I could go on down to category 4 of the non-emergency case. Obviously, category 1 and category 2 are our biggest concerns. And recently, in the last couple of weeks, thankfully, we've changed our resources in the Hillingdon group to provide more care for these high acuity patients, as we did see a dip in this performance. In terms of, we put on fast response units. So we've changed our model at the Hillingdon group and across London, really. It wasn't something specific to the Hillingdon group that we found that this difficulty was. But we found that actually with making sure that these cars are on their standby points, making sure that we had the right appropriate number of cars with the right clinicians on it, we've been able to bring the category 1 performance down within the government target for the last couple of weeks.
Could you just explain what your time should be for category 1?
Yeah, we aim to get to a patient from the minute the call is being answered to being at their front door within 7 minutes. And that is a significant challenge, but these are our sickest patients, and we rise to that challenge. And thankfully, over the past couple of weeks, we've got to that average. And it is an average. Obviously, there are times when the category can change. There are times when we just have difficulties due to traffic and things like that. Our biggest challenge at the moment is the category 2. So to give you an example of what a category 2 call is, that is our difficulty in breathing, our chest pains that can potentially come quite serious. And this is the challenge that we've got. Unfortunately, we are getting more calls than we have ambulances. The demand that's been referred to is staggering. And what we've got to make sure is we're using our resources and the rest of the departments in the ambulance service effectively as we can. Clinton's mentioned about Hear and Treat. So we have a fantastic team in our control room who can see perhaps some of the low acuity calls that are coming on and see if they actually do need an ambulance response. For various reasons, what we're told on the phone isn't always what we're presented with, and that's that's their moment of panic, for want of a word, or this is where they're really in need of help. And so there's various reasons why that happens, but our clinicians in the clinical hub will be able to maybe make a further assessment than our call handlers can do over the phone and get them into the right care without actually having to send a resource. So we've got to make sure we're using that department as effectively as we can. We also have the cycle responses down at the Heathrow Airport, which is part of our borough as well, making sure that they're getting to our patients in the appropriate way. And improving the education of our clinicians. We have a whole range of clinicians, right from critical care advanced paramedics to assistant ambulance practitioners. They all have a range of education, and making sure that they have the confidence to make the right decision so that we're not taking every single patient to hospital. And this is vital. So they've got the confidence to make sure they're referring it to alternative care pathways. Roughly, we take about 50% of patients to the hospital. This is a steadily improving figure. We want to take less and less But in terms of the hospital, I'm really grateful for the team at the Hillingdon Hospital for collaborating with us to make sure that we're doing everything that we can to ensure patient flow, and so you're not getting those photos outside Hillingdon Hospital. But I know that they work tirelessly at getting that flow correct. And it is a daily chat. I'm with Kirsty and the ED manager, constantly talking about how we can assist and how they can assist us.
It's good to hear you're in constant communication about how to resolve that. Okay. Does anybody, Patricia, do you want to mention anything about that particularly, or if not, that's okay? Sorry, just put your mic on.
Just to add to that, actually, the layout of our A&E department is not conducive to some of the actions that we're being asked to do now, which is like cohorting in corridors. You know, it'll be like this along the corridor if we cohort. So actually, I think that's been a real stimulus to us to work really closely with the local ambulance service to make sure that we get as much flow through and hand over as quickly as possible. It doesn't make it easy. You know, we do often at the moment, and it's getting worse, have quite a crowded department. And just with the sheer volume of patients that are coming to us. But where we have seen our increase actually is not in ambulance presentation, the increase has been in walk-in patients. Actually, that's where our biggest surge has been in the last probably 6 months or so. But certainly, I've been in the department plenty of times when there are lots of ambulance staff there, but we do actually pride ourselves in trying not to hold ambulances. It's getting a little bit worse than it was, but we certainly don't hold patients for hours and hours and hours.
Thank you. So yeah, Nikki will pass the statistics on to the rest of the committee. I mean, when we see you again in 6 months' time, I think what will be very interesting for us is obviously to see where that movement is, especially on the Category 2 stuff. Because obviously improving Category 1 is very important, but Category 2 can become very important, as you say. Does anybody have any questions? Rita? No, Rita, you go first. I'm the chair. I can call whoever. But you.
Thank you, Chairman. Clinton, I was quite impressed with this urgent care plan. So moving forward, I think I'd like to know the statistics for Hillingdon and how it's affected you guys. So I know we can't do them now, but moving forward, it would be interesting to know has it had an impact on you guys, and how many calls actually do end up going to A&E, or how many you can then deal with using this urgent care plan. So that's something that would be good.
So just be helpful for those who know and we were talking at the top about a three-letter abbreviation. So the urgent care plan is the evolution of the Coordinate My Care plan, the CMC plan, which most people hopefully would have heard about if they've been involved in that world. So the process has been there for a while, but it's about really improving it and its adoption, if that makes sense. And that was the key about the rebranding. It will be interesting to see how we could actually identify the improvement, because it may well be the plan enables us to make an improved process, if that makes sense. It might be quite difficult to give those figures, if that makes sense. But certainly in terms of the improvement, in terms of our staff being able to make an informed decision, and it may well be that the decision is either stay at home or go to a specialist centre, or not necessarily the acute, which is always the default, unfortunately, but actually go somewhere else. I mean, for example, we spoke about mental health services in Hillingdon. There's some other services that are coming available elsewhere in the boroughs. We also have mental health response cars that we're starting as well, which is basically a mental health nurse and a paramedic in a car, and it's about putting that expertise into the field. Our paramedics obviously do a wonderful job, but they're not mental health specialists. So we're trying to put that expertise out there, whether that's over the phone as well. So we also put mental health nurses in the control room as well, so they can do that process as well. And it's just about having that expertise and being able to make that really informed, safe decision for the patient. And very difficult previously, trying to do that over the telephone has been traditionally very difficult because of what Chris was saying about you don't always get the right information, or it's very difficult to triage over the phone. I mean, some of the mental health nurses that we have in the cars have absolutely made some truly fantastic decisions that paramedics would not be comfortable making out on the street. And I would say, again, from a collaborative piece, these staff it's a shame seeing CNW are not here, because they would definitely be happy with us mentioning that, because it is very much, and we come back to what was being said by Toby about workforce as well. We need to be really mindful that there's only X number of mental health nurses, and there's capacity, and with services that have been stepped up, there's requirements. in various parts of the committee. So what we've got is we've got some collaborative work where we're basically using the staff come to us from the trust, stay with us for 3 months, and then go back to their home trust, and that seems to be working really well. And it's about that holistic process. I know I've gone back out onto the wider system now, I'm afraid, Chair, but it's I think it's helpful sometimes.
It was relevant to our area, so I'm very happy.
Thank you.
Riti, so you want to come in on that?
Just to add, Hillingdon has the highest number of urgent care plans, and that's one of the joint projects that we've all done. So every patient in care homes has a urgent care plan, plus also the top sort of 2%, and plus there is a lot of push within general practice to get urgent care plans where the ceiling of care that the patient has wanted for themselves is clearly mentioned, so that the ambulance staff, when they come and attend to them, are very clear about what they need as well.
Sorry, Chair. Obviously, being new to the committee, so we're learning lots of new things as well. So I wasn't aware that the care plan is in place, but that's reassuring to know if I have to dial 999. But I would like to know, moving forward, how the improvements have been embedded and have they made a real difference to the borough. So maybe something that we can look forward to in the future.
I mean, I think really, if I may, this boils down to how many people we're taking to ED, really, because that technology that we're now getting to have that history, because people, we go in there absolutely blind. We don't know what's going on, and quite often the patient and their families aren't able to give us any history whatsoever. Historically, we didn't have any ability of getting that information or their medical history apart from just asking them. And so therefore, it's absolutely key, and I think it boils down to just how many people, our percentages of taking people to hospital, because with that information, we know what's normal for that patient and what's treated in the GP setting rather than in the acute. And this is something that's really quite exciting for the ambulance service, is the improvement of technology and how important it is to get the correct information at the time. I heard recently that we're now being able to use language line through our iPads as well, so we can get that clear communication when it is a challenge. Getting all that information, we can make a confident decision that they do not need to go to hospital, and then that will help the rest of the system. It helps out the hospitals who are not queuing and not taking people wrongly to. So it is really key. It's exciting as well.
Thank you. Philip.
Thank you. Just a quick question about timing. I mean, this all sounds very encouraging, and I welcome the information sharing. I think lack of good information sharing, it goes very much to the heart of problems with integration in the past. So I welcome that. I'm just wondering about, there's reference in the report here to a new contract starting with us from the 17th of November. I'm looking at the right page, but I'm getting a blank look there. That is correct, isn't it?
Does that have any more context, please? Is that talking about the 111 contract?
It was talking about the London Ambulance Service has recently been awarded a 3-year contract to provide the NHS service to the people of North West London. So that's what I'm referring to.
Yeah. That's to do with the 111 contract. So there's been some changes in the one.
Okay,
but ultimately, from an operational perspective, it's the same. It's just the contract essentially.
So my question is, all that we've been hearing about, how new is that? Has it just started? How soon can we expect to see perhaps some traction with some of the objectives here? Is it already starting to have an impact? Can you give us a flavour of that, please?
The short answer is most of the stuff that we've spoken about is in track and is in process and is in place. I think as Chris was saying, as we get into winter and we start to see the increases that unfortunately we're going to see. So I suppose the question is going to be when we meet in April is to see how bad winter was. It's probably going to be the yardstick that we'll use to see actually. If we was able to mitigate some of the extreme delays that we see, particularly around January and February when we get the really cold weather, if we're unlucky in this winter. So I think really probably, as from about the urgent care plans previously, I think the figure's going to be how bad was it at winter and how much were we able to mitigate during that process, I think is going to be the answer.
Thank you. Go for it, yes. Go for it.
Thank you, Chair. Actually, it's more of a comment than a question, really, because I just think that this information sharing is so necessary for looking after patients, and I'm really glad to see it. I'm just in some of the things that you were talking about in terms of the respiratory issues that you have in Category 2, and they're becoming one of some of the problems. I do wonder if this is kind of a lapse of COVID now, of the psychology of people coming out of COVID pandemic, and that breathing becomes their first kind of panic station when they can't breathe and they want to then call for help. I know from personal experience that would be something that I would struggle with, having known what my husband went through with COVID. So I just wonder if that could be something. And so for there, does the education also need to be then thought about to the patient as well as through the clinicians in there? And that then links back into the walk-ins in surgeries, because if we're phoning up 111 and we can't get the access to the GPs, in our panic we go straight to A&E and we don't wait for an ambulance, we just take ourselves there. So I just, in that joint up thinking, could that be it? It's just something that just came into my mind about that fallout after COVID pandemic and people's psychology of being in something quite extreme for themselves in a very difficult circumstances, and then coming out of that thinking, well, actually the one thing that's going to attack me is my breathing.
Yeah, it's a valid point. The difficulty we have with respiratory presentations is it can vary from a panic attack that has no pathology in the end, doesn't have any lasting effect, all the way through to something really quite severe. And it is a really difficult thing to do other than face-to-face, to really rule out a PE or other things that it potentially could be. It's a challenge. COVID obviously has got an impact on that, and people have got different different medical histories as a result of the last few years. I hope I'm not missing your question. I want to make sure that I'm clear on what you're saying. Really, we will always have breathing problems, COVID or not. We had them before, and it's something that actually is a category 2 call for 99% of the time, and we need to assess them. And it's only that we can be able to say if they go to hospital. And even then, in the assessment, there's a risk that we are under-treating if we don't take them in, because you can't really rule out a PE, for example, unless you've got some really thorough history taken. I'm really quite confident with your observations. So, have I answered your question? I hope it's a comment. Yeah. Thanks.
Sorry, it was just an observation. I'm just wondering whether the impact on your services is actually because of the psychology of people coming out of COVID. That was it.
I'd love to be able to answer that question.
I suppose one side answer to that is certainly during COVID, a lot of services that we had available to us, certainly about alternative services, stopped being available because we couldn't rule out COVID, and we couldn't do that. Now that we've moved beyond that, a lot of those services are stepping back up to their full processing speed, if that makes sense. So that's a positive, that as we're moving out, those services are starting to be able to take outpatients, which means less of our conveyances to ED.
You want to go in, yeah.
So I'm just going to say, so you are correct. So you've basically got three effects which are going on. So one is there are some sort of genuine sort of under-treatment or hesitancy to present during COVID, and to all other things being equal, there's a bounce back of the things we didn't see during COVID is now presenting. So that's definitely an effect. There is an effect from a sort of diversion from sort of other services, so things we stood down, and people are now sort of less aware of those things because we've got the habit of using them, and hence they are defaulting to to the sort of mechanisms which we clearly kept open during COVID. And then there's a third effect around sort of general sort of resilience of people to manage their own sort of health sort of issues, or to have the confidence to know that this one actually I can manage myself, or I can go to sort of this particular service. And that is driven sort of by the psychology, and it's by no means limited to respiratory. For all the reasons just laid out, respiratory is a particularly tricky one, but you see it across sort of quite a wide range of services. What we don't know is the relative magnitude of those different effects, but they're undoubtedly all coming through, and that is one of the reasons for this sort of quite sort of pronounced spike in demand which we have seen over the sort of the last months.
Thanks. Tony.
Yeah, sorry, I just saying that Chris was touching on about these 7 minutes call times, etc. I mean, we're all aware of this Hillingdon Borough, the size of it, and the length and breadth of it, and obviously it's challenging. Did you say you have units placed in strategic parts of the borough? You know, in hotspots, so-called hotspots.
Yeah, more details about how that sort of action team works would be interesting.
Certainly. So yeah, we have we have a double crewed ambulance, the ones that you see regularly, you know, around about where they have 2 crew members, and they'll be your transporting ambulance. But we also have the fast response cars, and these are the ones that we would not send on the lower acuity calls. We would save them really for the high category calls. And so their demand, you know, their utilisation rate isn't as high as the double crewed ambulance, who the utilisation rate's well up in the 90s. You know, they're call to call to call. And we do that on purpose to make sure that we can hit that 7 minutes for those really high acuity patients. And we review the standby points quite regularly, and we've recently done that to make sure that, so for the 3 or 4 cars that we may have on at any one time, they're not all in the same place. And so we'd have one up in Ruislip, we'd have one in West Drayton, we'd have one over in Hayes, and to make sure that we are providing that cover. Otherwise, we wouldn't have a chance. If you think about it, 7 minutes, 3 of that might be from call taking. You know, we really are up against it, and so we're having to think of innovative ways of making sure we get that.
Yeah, thank you. Yeah, it makes complete sense to me. It's a good idea, and it must be frustrating. I mean, I use Long Lane a lot. And it's constantly, I mean, I can guarantee 90% of the time there's an ambulance coming down there, and Long Lane's very busy, and there's always roadworks going on or whatever. Do you ever liaise with the public utilities or something about coordinating roadworks?
Yeah, we do. Regularly we get emails about potential roadworks, and it's a phenomenal amount, really. And what we've got to make sure, because obviously we're aware that these improvements have to happen. We're also part of, I have to sit on the HS2 meetings to make sure that there isn't going to be any significant, especially up to sort of Hovell Road and around Harefield Hospital. And they're very good actually informing us of these. It's something that we can never 100% keep on top of. We can't, you know, these improvements have to happen, and so we look at ways around it. But it is along with the traffic and all the other things, a challenge that we daily overcome. We just have to get around it, really. There's no solution to it apart from just safe driving and as progressive as we can.
If it's okay, I'll move on. So thank you very much for that update. Very interesting, and certainly something that we want to find out more about how that's all working. Patricia, thank you very much for sitting patiently and listening to everyone else. So as people have mentioned, winter is coming, and hospitals tend to get overcrowded in winter. So could you obviously tell us what you want to tell us, but also obviously talk a little bit about what you're doing to make sure that Hillingdon Hospital is able to cope with what might happen in winter?
So I should start by saying that actually winter is here all year round. So what used to be the idea that you had respiratory illness in winter and that made your paediatric unit or your adult unit more busy, actually we see a huge amount of additional respiratory disease in the summer now with allergies and so forth, and some of the pollution. Some of what we're doing now in boroughs is making a difference to that, but it doesn't feel like it lets off. There was a time when August was a quiet time in hospitals. It was probably our busiest time this year. So Nikki said that there were a number of new councillors on the committee. So I thought what I might do very quickly, because I'm conscious of time, is just set a bit of context for the Trust. So we have just published our new strategy for the next 5 years, in part because a lot of what people talk about Hillingdon Hospital is about the redevelopment and having a new hospital on the Hillingdon site. And we felt as an organisation that it was really important that we talked about what's the journey to get there. So for me, the redevelopment is a point on the journey that will give us amazing services, a much better set of digital solutions, much better facilities, much more modern care for our patients. But if we sit here now on our hands and let everything that's happening around us happen, and we make no changes in the way we provide our services, we will move old-fashioned practice into a new building.
Just sorry to interrupt. Could you send that to Nikki, or get someone to send that to Nikki so she can send it to all of us, because I think that'd be really interesting to us. Sorry to interrupt.
So if we move services that are out of date into that new building, we'll have exactly the same problem as every new build around the country has had, which is it's not big enough. Practice doesn't keep up with what's going on in the system. So So what we've done is we've had a look at our strategy for the organisation and said, what's our vision for the organisation? So we now have a new vision, which is to deliver the best possible care for those who need our services. And we very deliberately said need our services because it picks up on the issue about the diversity of our local population and how we meet our services to their needs. And we absolutely see that we do that in partnership. So with general practice, with our commissioners, with ambulance services, with our specialist services at the Brompton and Harefield. So we work very much in partnership. We've kept our cares values because actually, you know, I sign off complaints letters and I, you know, write in it and, you know, I'm very sorry that staff didn't comply with our cares values, and actually I feel very sad when that hasn't happened, but they are really important. So how we communicate, what people's attitudes are, how we deal, what's our responsibility for care, how we provide equitable care, and very importantly, how we focus on safety. And we absolutely know that we haven't and don't always get that right. So we've got now 6 strategic priorities. I think they're all fairly obvious. None of them will surprise you. So it's about quality. It's about our people that work for us. It's about making sure that we perform to the standard we're supposed to perform to. It's about making sure that our finances are right so that we're using the resource we get from our commissioners in the best way for our population. One thing that is really important, and I'll come back to in a minute, is how we work in partnership. We are, in size terms, a small to medium-sized district general hospital. We are enormously important for the population of Hillingdon, but there are some services that we just cannot provide at the scale that would make it safe or provide the best quality service for patients. So, you know, for instance, with respiratory care, we share consultants with the Royal Brompton because we get the creme de la creme of consultants who get to do their research, get to do their specialist piece at Harefield, but come and provide really high quality general care. And an example of that would be where we've rebuilt some of the wards at Hillingdon in the last 12 to 18 months. We've created a specialist respiratory unit, and that was built on the back of needing a step down from ITU for patients who didn't need ventilation, or a step up to ITU, patients who didn't need ventilation but needed to have nasal oxygen or oxygen through masks. And what we've been able to do is use that specialist expertise and consolidate our services all in one place. So that's really important to us. And then obviously, so those partnerships are really important. And then the 6th strategic priority is about our strategic programs. So our strategic programs are rebuilding the hospital. That we have a program about making sure that we have a completely up-to-date patient record. So our electronic patient record that everything gets recorded on. We currently have a whole hodgepodge of different IT systems. So a consultant or a member of nursing staff in the trust will have to log on to several different systems to be able to record observations or to be able to record the medical record or to discharge a patient. And by the end of the next calendar year, so from November 23, we will have implemented the Cerner solution. So that is a solution that's in place at Chelsea and Westminster and Imperial. And we're currently implementing that solution at London North West and at Hillingdon. So we share IT resource. So by the end of next year, all 4 hospitals will have a single IT system. So if you're a patient at Hillingdon but you need to be transferred to St Mary's for a specialist procedure, we don't have to discharge you and re-enter you at St Mary's. We'll be able to do a complete transfer of care. And with my digital hat on, what that will mean also is that we have the WISIC system, which is the community-based system that links in with general practice and with community services in North West London. We'll be able to bring all of that information together. And what that will give us is an enormous linked, integrated database of information about patients, which means almost wherever you are, we will be able to get information about you and use that in terms of helping with proactive care. So what do we know about our population? Do we know that we've got populations that we're missing? What do we know about you as an individual? And are we making sure that we're targeting your care appropriately? So it will be preventative care and treatment. So for us, the IT solution and moving forward with the hospital redevelopment is really important. We're progressing well with hospital redevelopment. We're just waiting for the Treasury announcement about the next tranche of money, but we're reasonably confident that we will get that and we will move forward.
Do you know when that announcement might be?
No,
okay,
is the answer to that. It really does mean, it depends when the Treasury...
There are so many different steps, aren't there, that need to be signed off on this process.
But you know, we're also very engaged with the local authority at the moment because we're going through our planning application at the moment. So that piece of work is moving ahead very positively. In terms of partnerships, we're an organisation in our own right. We have certain care that we have to provide as an individual organisation, and we're held to account for that through the integrated care system, but also by the regulators, so CQC, the Health and Safety Inspectorate. In addition to that, we've had now for some time a very positive partnership with Hillingdon Healthcare Partners about how we work around that collaborative, integrated pathway. And we absolutely think it's important that we are part of that journey for a patient in Hillingdon who only needs care in Hillingdon, that they would be treated as close to home as possible, that we would support general practice. So we have a system called Advice and Guidance now that means that general practitioners can submit information about a patient. Our consultants will look at that information, make some decisions about what care that patient might need, and then can advise general practice. So not all patients have to come to hospital now. They don't all have to be referred. Our consultant might say, well, actually, if you did this diagnostic test, we could then reconsider what care might need to be done. And actually, we are an exemplar in London about using advice and guidance. And actually, what we're starting to see is a reduction in referrals to the hospital, because patients can be treated closer to home. So that's a really positive step. And we're doing, I think, over the next 5 years, we will do more and more about how we either have joined up care between primary, community and mental health and the acute sector, but also where we will gradually move care out of the hospital so that patients actually don't have to come to hospital at all. And then the final piece that is actually very new and has been in place since the beginning of April is that Hillingdon Hospital is now also part of an acute care collaborative. And that is again part of the national direction about collaboratives of providers. And where that is a huge benefit to us is that it means now that we're working collaboratively with Imperial, Chelsea and Westminster and London North West. We are an equal partner in that partnership. We now have a single chairman across the 4 organisations. We are still operating as unitary, statutory organisations, but where we can, we're working collaboratively on programmes of work that will benefit care. Some of that is things like back office, so we're looking at whether or not we can have economies of scale by working more closely together. But we're also looking at that, and this is not new because actually we've been doing it for some time, is looking at where we've got services where, and an example I would use is that we have a renal service at Hillingdon, but the tertiary provider for renal services and renal dialysis is Imperial. And therefore we work very closely with that tertiary provider to make sure that we've got the appropriate service locally, but we wouldn't be providing full-scale dialysis and renal services at Hillingdon Hospital. So we're working very closely with our partners to think about where a service is best provided, how do we make sure that patients have access to the highest quality care. But what is absolutely clear is that in terms of what I would call our bread and butter services, which is high quality emergency care, elective care for the operations that need to be done close to home or outpatients that need to be done close to home, that absolutely is what we're here to do. So that just gives you a bit of a flavour of where we are. A couple of quick things in terms of quality. A number of you will be aware that there have been some concerns about the quality of care at Hillingdon Hospital for some time. We are rated as inadequate for the Hillingdon site. We haven't been re-inspected by CQC, which is somewhat frustrating because of the way they do their inspections. They were just due to re-inspect the trust when COVID hit. We did have a visit in the middle of 2020 and we got a number of improvement notices. We've worked very hard on that and they were removed last year. And in fact, we had an unannounced visit on the 1st of November to look specifically at some of our medical and care of the elderly services in response to some concerns that have been raised by patients with the CQC about the quality of care. And actually, we haven't had our formal report yet, but our informal feedback was that they were very pleased to see that the things that patients had raised, actually we'd taken action on. So that was very positive for us. So that's where we are on quality. Done a lot of work on quality. Still a long way to go, but absolute improvements in the way we're providing care. And then the other thing is just picking up on where we are on winter. So the key performance targets that we are monitored on are the urgent and emergency care, and that's the 4-hour target in A&E, so from time of presentation to a decision to treat and either discharge or admit. Our 4-hour performance, like every trust in London, is actually way below the target we should be achieving. So we were holding our own pretty well at around 70% of patients being seen within 4 hours. And that's a combination of ourselves and the Urgent Treatment Centre, which is run by Totally. That performance in the last 2 to 3 months has deteriorated. And in part that is the sheer volume of patients who are coming through us. So we are, and I need Tina to tell me on this, but we're sized for about 130 to 150 patients through the doors every day, and we regularly top 200. So that's just in A&E, not including the Urgent Treatment Centre. So we see about 400 patients a day, and that's a big number of patients coming through the department, and it is not a department that is fit for purpose for that number of patients. So our performance is not good. We also are now monitored on 12 hours in the department, and we're just about holding our own, but actually our performance could be better on that. So big focus over the next few months about how we can change our position on that. And then in terms of elective care, the expectation is that we should have returned to 1920 levels of elective care. So that's outpatient appointments, day surgery, day casework, and inpatient elective care. Actually, we have taken some time to build back up to that, in part because our theatres were occupied with critical care patients for quite some time. But we are now back to over 100% of patients being seen. We're confident we'll hit the nobody waiting over 78 weeks by the end of this year, which is the target we're working to. But it's quite difficult, and COVID hasn't gone away. So we still have patients with COVID in the hospital, and that means we have to work very hard to make sure we segregate those patients and that we're not infecting patients when they're in hospital. So that's where we are. We've got lots of contingencies in place for winter. We've got some extra beds open. We're working very hard to maximise our use of virtual wards, where we use IT to monitor patients at home. That's again a national imperative. And we're working very hard to look after our staff because they're tired. This has been quite a strain over the last 2 years, and everybody kept thinking COVID had gone away last winter, and it really hadn't. So it's also about looking after our staff.
Thank you. There is so much happening in health across everywhere, isn't there? It makes me very pleased that you're keen to have the CQC to come to you to inspect you. I like that. That's very good, because that is something obviously that is a sort of shadow, isn't it, over Hillingdon Hospital at the moment, so we would definitely welcome that as well. The question I'm going to ask actually is about staff and staff morale, because I think certainly a couple of years ago staff morale, and even a year ago, possibly wasn't where we wanted it to be. Also at the same time, competing for staff in the health sector is really, really troublesome. I know lots of people are having problems getting staff and maintaining staff. So what are you doing in order to make Hillingdon Hospital a place where medical professionals want to work?
So you're right. Staff morale was very poor at Hillingdon, and we've seen it drop over the last few years. You can see the drop from about 2016. We managed to hold our own last year, so where we'd done some very specific work around staff morale and well-being, we didn't drop any further, but actually on all the indicators that the NHS as a whole dropped on, we continued to drop. Could I say with confidence that that will be any better this year? No, I can't. And that is a factor that is driven not just by what's happening at Hillingdon, but just the economic environment that we all live in, and the fact that many of our staff have to drive to work, so they have the cost of getting to us. Public transport is more expensive, all of those sorts of things. What we have done is we were very lucky to get some funding from the ICB at the end of last year to actively recruit, to go out to recruitment internationally for nurses. So we had high vacancy rates for nurses. We've recruited about 120 nurses, and virtually all of them are in post now. So our vacancy rate for nurses has dropped dramatically. In some of our medical specialties, we were having difficulty recruiting, but actually we don't necessarily get huge numbers of people applying for consultant jobs, but what we are getting is some really high calibre individuals. I haven't been on a panel in the last 2 years where we haven't recruited really high calibre people, and we've got a cohort of young enthusiastic consultants coming to the trust who actually see coming to us where we will be working in that collaborative really beneficial, because they can come to Hillingdon, but they'll also be able to keep their expertise in tertiary services by working at Imperial or other places like that. So, and then we also work very closely with our local population, so we have quite a high turnover of healthcare assistants and estates and facility staff, but we do predominantly recruit locally. And for those of you that are not aware, all of our facilities and estates functions are insourced, so it is our own staff, and we work very hard with them to make sure that they feel very much part of the Hillingdon family, if you like. So I wouldn't say we've got it completely right. I'm not confident that we're going to get a more positive staff survey, but we've been working really hard to try and tackle the things that staff have said, actually this doesn't work very well at Hillingdon. I think, for, again, those of you who don't know, we've had a huge turnover in senior leadership, so I will have been at the Trust 2 years at the end of this month.
It's lovely to see you again.
Thank you. But I'm something like the 5th chief executive in 5 years, or certainly in the last 7 years, and that doesn't create much stability, and we've had a lot of churn at senior leadership level, but at the moment the plan is that we keep the stability, which is good.
No, thank you for all that information. That's really useful to know about, so thanks. Philip, you had a question.
I did. Firstly, I'm glad you touched on the improvement journey, because I was going to ask about that, but I don't need to now. What I do want to ask about is discharges, delayed discharges, where we are in relation to that. I know there's the perennial challenge of the tie-up between social care and the trust in relation to that and how that works. We've had discharge to assess for a while now. Wondering how that's all panning out, really, and what your assessment is of the current situation, please.
So discharge is monitored very closely in the trust and at a national level as well. It's become one of the big priorities. So the first thing to say is a huge thanks, because we have a long-standing, very positive relationship with the local authority. And although actually I think across London, particularly across northwest London, where discharge to assess was originally born, if you like, actually we found it a very good process, and it's a pity in a way that we've lost that. However, what we haven't seen is a massive decrease in our performance in terms of discharge, and the reason for that is that with CNWL we have a joint discharge team. So we have a discharge team that basically works into the hospital and pulls people out into the community. Discharge to assess made it better, because we could move people to a placement whilst they were waiting to find their final placement. We are still trying to make use of a modified version of that, and actually we're using our discharge lounge a bit more in relation to that. So patients we know are due to go home, we take them to the discharge lounge the night before so that they're ready to go. And at the moment, touch wood, we had a little blip when discharge to assess was removed, but in fact we are currently seeing a holding of low levels of patients waiting more than 21 days to be discharged. and we're holding our own. In fact, during the latter part of last year, our length of stay increased, but largely because of the way we were managing care, because we were having to move people around because of COVID. But actually, we've seen about a 1 day drop in length of stay, so that's really positive.
Any other questions? Tony.
Yeah, thank you for your presentation. I found it quite enlightening, actually, and interesting. And the bits where you said about services, you're looking at what services you can provide. Because I had a constituent contact me about the physiotherapy service, and she said to me, they're taking it away from Hillingdon Hospital. I said, no. So, but it's interesting what you said about looking at what services you do provide, and whether you could work with partners, or whether that message has got mixed up somewhere along the line about things. I don't know.
So I think one of the physiotherapy is actually a really good example where physiotherapy is provided by the community trust. So CNWL provides physiotherapy as well. And so we predominantly provide physiotherapy for patients who are inpatients. When patients go home, there's a joint assessment with the inpatient therapists, and if somebody needs therapy in the community, there'll then be a handover to the community team. And I think sometimes the message gets a bit muddled about when physiotherapy in the community is going to be started, because there's a handover process and then a process for re-evaluating what people want. So I think that's probably where it's coming. I'm looking at Richard, but I suspect that's probably what it is.
If I may, Chairman, yes, I'm sure you're right, and I'm aware that through the primary care networks, we're also recruiting a number of physiotherapists so that GPs can refer patients to general practice. I guess the risk about having several providers is that, as Patricia says, that may be confusing for patients, particularly in the transition from A to B. But yeah, just to confirm, I'm sure the hospital physiotherapy is remaining in place.
Thank you. That's very reassuring.
Great. So, right, if I move us on to our final guests, my promise to you, Nick and Deval, yes, is that you'll go first next time. Okay? So, take it away. You are the finale.
Thank you, Chairman. I laid out the situation actually for the October or the September one. So things have changed slightly, and I'm sure Derwell might be able to give an update on the cases. We are doing well on our elective recovery. That's partly because we weren't quite so affected, particularly at Harefield, by COVID. The Brompton was, because it pretty much shut down most activities to do ECMO for COVID patients. But the Harefield and pretty much Barts were maintained cardiac surgery and cardiology for London. So we didn't actually start with the same deficit as a lot of other more routine waiting lists doing. And we are still maintaining that we don't have anyone waiting over 18 months. And we can active monitoring on people on waiting to ensure they're not coming to harm. In that regard, in anticipation of the RCN going on strike, we are in conversation with the Department of Health and the RCN that cancer and cardiac surgery are derogated from that, and that we're hopeful that will take place. So that might not be, it might not be as affecting as it will be on other areas. But it's probably worth reporting that the overwhelming vote from the nursing staff in the trust is in favour of a strike, very, very heavily. We're pretty much out of COVID. I shouldn't say that, should I? We're having problem with recruitment in the main areas of critical care nursing, although that's improving. Radiographers and cardiac physiologists, but we've started some very close working Brunel, who are looking to expand from their recently opened medical school into cardiac physiology and perhaps even a radiographic branch to that in the near future. And we're doing well on overseas recruitment. Everyone knows that the constraint on capital expenditure, apart from the greedy big hospitals trying to steal it all for their new builds. We did have a very helpful visit from a hard-working and trustworthy local MP. That was David Simmons, who wrote on our behalf to the Secretary of State for Health, except the Secretary of State for Health 3 ago, and I'm sure we can recruit him again, because the Seedale restrictions are fairly crippling to the NHS, and we've got some wards and 2 wards and 1 theatre in particular, which will need replacing in the next couple of years, and unless Treasury does something to start releasing money for spending on the NHS, it's, well, I don't know quite what we will do, but it'll probably mean restricting services if the wards fall out of fashion and aren't replaced. That's it from me.
Yep.
Don't know if you want to update on where we are with the waiting list.
Yeah, I think it's probably worth mentioning that we have seen an uptick in our non-elective activity, which the balance of elective to non-elective that we saw pre-COVID to what we're seeing now, it has changed a little bit, so that is affecting part of our elective recovery programme. We've been working with various people to try and work out why this is the case. Is it that people have not gone and sought medical attention soon enough and therefore they're getting ill before they go to hospital? But it's quite non-conclusive at the moment. In line with that, Nick mentioned how we're monitoring patients on waiting lists because they are waiting longer than they did pre-COVID. We have just rolled out digital platform that allows patients to monitor their symptoms and communicate with the hospital in a continuous way to flag if they're worried about their symptoms or anything changing, which then triggers a clinician review. So that has now been rolled out across all of GSTT sites, so Brompton, Harefield, Guy's and St Thomas's and also King's, and that's proving very, very successful. It's actually a digital project that's funded centrally from NHS England, so this might be the way that people monitor deterioration on waiting lists in the future, but I think that's the only addition.
Great, that's all good to hear, apart from your lack of ability to get funds, which but I'm glad you've enlisted the local MP to write on that. Does anybody have any questions? No. Oh yes, go on, Sital. Go on. I moved my head too quickly.
Sorry. Thank you very much. It just interested me about this non-elective and elective kind of surgery, because I'm just going to put it out there. Just experiences that I've had with constituents, with residents in my ward, is that sometimes because they're so struggling to get to see somebody, or because they get sent home saying that, oh, you'll be fine, do this and do that and blah blah, that sometimes at the first level something more serious isn't diagnosed. So therefore, is that why that's happening? Or is it because there could be all sorts of reasons, but I'm just wondering, in this kind of arena, and it's awful that we have to focus on GPs because it's really unfair, and I appreciate the demand is going crazy, but I just feel that is that another bit of joint-up thinking that needs to take place somewhere?
It's almost impossible to say for certain what it is. A lot of things could be contributing, but it is a pattern that's been seen in all cardiac surgery units across London. We did have a huge dip on cardiac surgery referrals in an elective manner into the hospital during the sort of the COVID and the post-COVID phase, so it might be that's probably the most likely reason, is we're now seeing those patients further down the cardiac disease. But it's very hard to tell, despite all the analytics we're doing with the data. There's so many contributing factors, it's hard to say for sure.
Okay, well I'm going to call this item to an end, our one-item meeting, which lasted over 2 hours so far. Thank you so much to everyone who's come and spoke to us. Obviously we look forward to seeing everyone in 6 months' time and getting further reports, so thank you. So you're all welcome to leave while we discuss our final couple of agenda items. Thank you.
Thank you.
Thank you. Right. Okay. Apologies, I want to shift through everything if I can in 5 minutes. Now that I've said that, it won't happen. Okay, on the Cabinet Forward Plan, where are we looking at? Sorry, my papers. Yes, the one thing that I had a question about actually is on page 1 of it, the 2022-23 Better Care Fund Section 75 agreement. I mean, that looked quite interesting to me. Nikki, could you see if maybe that's something that should come to our meeting, a subject that should come to our meeting in December?
Chairman,
do you know more about it?
Chairman, I have already contacted, I think you raised this at the last meeting. I already contacted Gary Collier about this, and he's happy to come along with Sean Bidewell, who's the Borough Lead on North West London ICS. So the two of them are coming along to the meeting.
I'm glad in my absent-mindedness I'm consistent at least, so that's good. Okay, does anybody else have any other questions? No, fantastic. On the work programme, now at the last meeting, me and Nikki were tasked to go away and look at adult mental health and children's mental health to see which one of those would be the best one for an in-depth review. And they're both very, very good cases. But essentially, what we've discovered is that children's mental health is probably the better one for us to do an in-depth review. This is because it appears that there may be some issues with regards to the referral of the CAMS process. Clearer information needs to be provided to patients in relation to the referrals process, time pathways, also between the different services. Things seem to be falling between the gaps, and I won't go into this too much, but I had the privilege of meeting some parents whose children have gone through the service, and they've told me things about certain decisions that were made, which I think shows a service that maybe could use some scrutiny and maybe some outside advice in terms of how to join up better. So my recommendation is that we look at the children mental health services. Philip?
I support that, notwithstanding the impression we got at our last meeting, which I had reservations about, to be honest, and I said so at the time. No, I concur entirely. Yeah, thank you.
So, yeah, Sital?
I just thank you, because it's a really important agenda that post-COVID has affected so many children. I personally know about this because of the amount of people that I support with mental health issues in children, and I'm really grateful that this committee is going to be doing that.
Thank you. I have to say, when looking into it, it seems like a big but very worthy task, I have to say, having spoken to a few people about it. So if we're all happy, Nikki will go away and draw up terms of reference for us to look at our January meeting, and then we'll start our in-depth review and see if we can help hopefully improve how the system works. Okay, we all agreed? Fantastic.
Agreed.
Fantastic. Is that the end? That's the end, isn't it?
Okay, so...
Brilliant. Okay.
Did you say so, Chair?
I say so. Thank you, anyone who's still watching us. And obviously we'll look forward to seeing all of those who will be with us in December. Okay, thank you.